Okay, welcome to the lecture on iontophoresis here. We're going to talk a little bit about this and just kind of review the basic concepts before we really practice it in lab. The first part to talk about is the basic principle. So you have like charges repel and opposite charges attract. So what law is this? This is a law we're going to come up again and again, Coulomb's law. So very, very important law to look at. Okay, so let's look at this picture down here. Although the picture is in black and white, you can see right here you have a red electrode, so that would be positively charged. And then you have a black electrode, which would be negatively charged. And you could also tell by the size that this one is smaller and this one is a larger electrode. So you have the active electrode here, and then you have the dispersive electrode over here. So based on that, we know that the medication would be going into this from this electrode, driving the ions into the skin, and then the current would then be closed. The circuit would be completed through the dispersive electrode there. So based on this, if we look at Coulomb's law, we're taking like charges repel. So if we have a positive electrode here, we must have a positive medication. And pause and think about that if you need to, but we're going to keep moving on here. Okay, now what are the two methods? Primarily, we just showed you one there, but basically, you could take positively charged electrode, or the anode, and then you can take positively charged ions. Or you could do the opposite. You could take negatively charged electrodes and drive in negatively charged ions. But ultimately, the main point of this slide, and the most important part to really look at, is the stratum corneum over here. So this is the outermost layer of our skin, and that is the main barrier to preventing anything into our skin. So that is what we have to get. It's lipid rich, and it's approximately 3 to 5 millimeters, and then 5 millimeters will be obviously half of a centimeter, or 0.5 centimeters. So you can see it's a pretty thick layer, and we have to get through that. But once we get through that, then we can get over here into the vascularity if that's what we want, or we can get into the connective tissue or the other tissue that we may want the medication to be in. But keep in mind, once we get past the stratum corneum, we are close to getting into the superficial vasculature and capillaries. So that's what the important thing, stratum corneum. Okay, so thinking about that, what happens when you get a tattoo? If you get a tattoo, you're looking at the medication, not medication, but the ink going in through the stratum corneum and into the subcutaneous tissue and into the dermis. So can you do iontophoresis over a tattoo? Well, I'm going to best answer this with what we call a triple negative, which is great, right? So it's not fresh, and it's not inflamed, it's not a contraindications. So it's okay to do unless the patient just got the tattoo and or it's inflamed. So there you go. There's your little triple negative. Okay, we'll keep moving on here. Okay, so what are the components of the iontophoresis unit? Basically, we're looking at an E-stim unit here. It's a power source, and it's going to deliver DC current, either positively or negatively charged through the electrode that we're dealing with. In this case, we're dealing with a negative electrode, or the cathode. And then on the positive electrode here, we're just looking at water. Now, in order for this to work, the negatively charged electrode over here has to have medication that is water soluble, and it has to have a certain molecular weight, under 5,000 approximately. You do not need to know that though, but it has to be of certain consistency. So these medications will be compounded at certain pharmacies, and the patient will bring that medication with them. Typically is the way that this will work. Now, one thing we always have to be aware of is that the skin is unbroken. The skin is okay at the treatment site, or else the iontophoresis may cause some further irritation and or could open that area up for more infection. So we do want to make sure the skin is okay, and we will look at the parameters next. Okay, so medications. We talked about this now. The very important thing about this slide, very important, is to look at the depth of penetration. So you're looking at 3 to 20 millimeters. 20 millimeters would be the same thing as 2 centimeters, which was roughly the same as which other modality? Ice and moist heat. So we're looking at that different distance. Also, this glass article found it approximately to be 1.7 centimeters or 17 millimeters. So this gives you an idea of the target structures that you're looking at. Very superficial structures such as tendons and superficial muscles, but over the plantar fascia, over the Achilles tendon, patellar tendon, lateral or medial epicondyle areas. Those are the places that iontophoresis is typically administered to. Okay, so here you go. Little Chuck Norris for you. You only have one option if he's calling. Next slide. Now, this is another very important slide here to look at the medications. So what are the commonly used medications? I put them down to the top 4 right here. So you have hydrocortisone and lidocaine. Those are both going to be positively charged. So if they're positively charged, we know they are going to go under which electrode? They are going to go under the anode. Now, you have dexamethasone, which is negative, and acetate, which is negative. So where are they going to go? Under the cathode, of course. So those things are important to remember. But let's look at each of these as to why we're going to use them. Hydrocortisone would really be a corticosteroid, so not an anabolic steroid, but a corticosteroid, and that's going to decrease tissue inflammation. So if a patient is having acute inflammation, and think about the cardinal signs that would be associated with that and the general time frame that would be associated with that, hydrocortisone may be commonly used. Now, going back to phonophoresis, remember that phonophoresis typically is 1 or 10% hydrocortisone cream that we could use. But if the patient is having inflammation, hydrocortisone would be a good choice. Now, if they're having inflammation, dexamethasone is also a good choice, and this is negative. So this is again a corticosteroid. So when we look at both of these, hydrocortisone and dexamethasone, they are corticosteroids. So those are going to decrease inflammation. Let me delete some of this here. Okay, so now you have lidocaine as well. Now lidocaine is not a corticosteroid, but it's an anesthetic agent. So it's going to decrease pain or anesthetize the area. Just like Novocaine, before a dental procedure, lidocaine would anesthetize the area. Acetate is going to look at something different. It's going to dissolve calcium deposits. So if there is a calcium deposit, and you may think of some conditions that go with that, like myositis ossificans or calcific tendinitis, commonly over the bicipital tendon, proximally, long head bicipital tendon. That's a medication that may prove helpful. So look at these medications and understand which medications are positively and which medications are negatively charged, and think of indications for each of these medications. Now let's talk about what the research says about iontophoresis, in particular the medications. One of the things most commonly studied with iontophoresis is a condition called hyperhidrosis. What would that be exactly? Okay, I'll give you a few words to describe this. So someone perspires excessively, which would be the same as sweating, or sometimes we describe patients medically as diaphoretic, or they're experiencing diaphoresis. So all of that has to do with the sweat glands and the fact that the patient is sweating excessively. Now, this could even be at room temperature. It doesn't have to be in hot, humid weather outside. Looking at this, let me delete some of this. What does the research say? Well, this is one of the rare times when the research, pretty much every study done, says it is beneficial throughout a large time period. So if a patient is having hyperhidrosis, and we would use tap water over the active electrode and saline over the dispersive or negative electrode, essentially, that is really going to zap those sweat glands initially. But like any kind of treatment, it's going to have to be carried over every few weeks for maintenance. So you're going to really somewhat destroy these glands and prevent them from sweating as much. But why would hyperhidrosis be a dangerous condition, or why would we have to address this with patients? I don't want to give you the answer. I just want to leave you here to think about what condition or what occupation could this be a real issue with, and dangerous and possibly even life-threatening. Because we joke about sweating too much, but just think about that and why we may need to treat that. And we'll move on to the next slide here. Okay, so let's talk about some more research studies here. And let me just kind of preface it with this.
They've done studies, 60% of the time it works every time. That doesn't make sense.
Right, so that may not make sense, but some of these studies do make a lot of sense, and they are pretty good. So what are we looking at? We're looking at rheumatoid disorders like RA. And so RA is obviously an inflammatory condition, so you'd pair that with a corticosteroid to decrease the inflammation. Is it effective? It does seem to be pretty effective over that. Epicondylitis or algia, that's a superficial structure. It does seem effective. So naproxen, you're probably familiar with Aleve. That's kind of the over-the-counter form of that. And dexamethasone, we know, is going to decrease inflammation as well. But still, one good study here also had mixed results. So epicondylitis is very questionable. And you see some other diseases. TMJ, this may be something we treat a lot as physical therapists. It's possible the active electrode in that case would have to be very small, and that is a possibility as well. And for the acetate or acetic acid, it's really overall two good studies show that's not supported. So it is a commonly used medication, but the research does not seem to support it. It does seem to support plantar fasciitis, but overall there's some debate on this. Let's go to another slide and look at some more research. So there's just been a few random conditions here. We talked about myositis ossificans later, using acetate to break down those, but there really was only one study on that, and it was a low-level study. But there are some studies, but overall there aren't many studies to support a lot of the iontophoresis use. So clinically, when you get out there, I think you're going to find out there's a lot of hesitation among clinicians to use iontophoresis because the lack of research, and a lot of insurance companies will not reimburse for it and will make the patients pay out of pocket. So that's another roadblock with iontophoresis.
Hey, boo-boo, is that some zinc in the picnic basket? Because that would be good for treating a wound. Hey, boo-boo.
Okay, well these you should all know. They're the same exact thing as E-stim, so definitely pacemaker, in particular demand type pacemaker, but pacemaker and or arrhythmias. And then we're looking over the carotid sinus is a no-no. low back with pregnancy, and then you're looking at thrombophlebitis / DVT. So those would be the typical contraindications, but also allergy to the specific medication being used. So that's an obvious thing. This isn't too much of an issue for us because the patient is going to get the medication prescribed to them by a physician. So we really are only the executors of the iontophoresis. We're never going to prescribe it, at least in our setting, in the civilian physical therapy setting at this point. So there is an allergy, and we always need to double check this with the patient. We're going to explain to them what medication the doctor has prescribed and to double check that they are not allergic to that medication. Okay. So the other precaution to look at is iontophoresis is going to be not applied after another agent that may alter skin permeability, such as heat, ice, or ultrasound. In particular, heat will cause, what does it cause? Vasodilation and increased blood flow. And that's going to accelerate dispersion of the drug from the treatment area. Which other modality was this also similar to? When you think about it, it's exactly the same situation as phonophoresis. And that's why phonophoresis is typically administered pulsed, because we do not want the thermal effect of the ultrasound to cause any further vasodilation. So this is very consistent with phonophoresis. Okay, so for this slide, we're going to go over the calculation. Now, I do want to say this is going to be important here. So make sure you know this. Looking at this, we're dealing with milliamp minutes as the dosage. So a dosage could be 40 milliamp minutes. That will be the unit of measurement for this. The current, as you know, is the same as the amplitude or the intensity, and this is what you're going to turn up with the patient. And then the treatment time is typically going to be in minutes. However, with some of the portable ones, they could be distributed over an hour period, such as 12 hours or even 24 hours with some of them. So we're looking at 40 milliamp minutes as an example. So if you had the intensity turned up to 2 milliamps, and think about how much 2 milliamps, it's a very low intensity. So what are patients going to experience? Probably not much with this at all. They're probably going to feel either nothing or a very slight tingling. There should not be any motor response with this at that dosage though. So if you do it at 2 milliamps for 20 minutes, you would get 40. What if you do it for 2 milliamps and you do it for 40 minutes? Your dosage would be 80 milliamp minutes. Now I'll go to this next slide and we'll look out on the machine how it's set up. Okay, so typically on the machine, what we're going to enter is the dosage here. And then we're going to fluctuate the current. So let me get my laser pointer out here. Okay. So the dose you enter on the machine, you see how it says 40 there? So that dosage is in 40 milliamp minutes. You do not set the time necessarily, but you set the current. So what happens here is as you increase the current and turn that up, the machine's going to automatically calculate this and it's going to decrease the time, or vice versa. So it's another inverse relationship between time and current. And what the machine's going to do is going to keep a running total of how much dose has been delivered, and so as the time counts down, the dosage is going to count up and the current is going to stay the same, typically at whatever you set that, whatever number that is set on the beginning. And then we'll go over this in lab, but this is the basic overview. Now, this is another type of machine. This is the Chattanooga Dupel type machine. So you have what you have here. You have two channels, channel 1, channel 2. You can see channel 1, channel 2. So often you're only going to use one of these, but it's picturing there the dosage for channel 1 or channel 2, but that's in milliamp minutes. That's how the dose will be determined, milliamp minutes. Now, why do we generally pick 40 or 80? Because those are going to be the most commonly used milliamp minutes you see. Well, looking at the research studies, there's been some research studies over time, and basically how much they used is about 80 milliamps. So that's how oftentimes the recommended dosage is 80, but in some treatment areas it would be 40. So 40 or 80 are typically common amounts for the dosage of the iontophoresis. But of course, let's look at what the research says here. This research study from 2011 compared basically 40 and an 80 and another knot for you. There were not any significant differences between the high dose of 80 and the standard dose of 40. And this was with lidocaine, so you could assume at that point that they wanted to decrease the pain or anesthetize the area in some extent. So 40 and 80 showed no difference. However, a lot of clinicians feel that if they already have the medication and they have the antiphresis unit and the patient is paying out of pocket, they might as well give them the 80 instead of the 40. So it's not clear what the research says on this, but at least according to this study, that there's no difference. Okay, and then this will be the very last slide, typical skin reactions. Because this is DC current, there is the possibility of some skin irritation or erythema present there. It is less frequent, but there could be some bumps, or it could be allergic response caused by the release of one thing that goes with inflammation that we talked about before, histamine. And where is this released? Histamine is triggered out of the mast cells. So these may disappear over the few minutes. So this is something we have to monitor the patient for and see how they respond to this DC current. So the first time a patient receives antiphresis, you may want them to stay after in the clinic for a few minutes after the pads are removed, and just to monitor their skin, and also to educate them about the skin response if they are taking a take-home patch with them instead of the in-clinic patch. Okay, so there you go. That's the information for antiphresis.
One.
Hello, Daniel.
One.
My name's Andrew. I'm a student physical therapist at Radford. How are you today?
I'm pretty good.
Today we're just going to do some iontophoresis on your elbow. Is that okay? Do you know what iontophoresis is?
I haven't a clue.
Okay, well basically we're just going to be putting some anti-inflammatory medicine inside your body, and it's going to make you get better. Okay?
Is it painful?
It shouldn't be painful. You'll just feel sensation, maybe some light tingling, but if you feel any pain, you let me know and we'll quit. Alright, so before I begin, I just need to ask you, do you have any history of blood clots or anything like that? You don't have a pacemaker or anything? Okay, good. So first, I'm just going to test your sensation, and this is sharp, this is dull, but it won't hurt. So that way you can know what I'm talking about, I'm just going to test your knee first, and then we're going to do it to the area that we're going to apply this to, okay? Alright, so this is going to be sharp. Feel that? Okay, and this is going to be dull. Okay, now close your eyes. Go ahead and lay your arm up here for me. Alright, close your eyes, and I'm just going to test several areas of your arm. You just tell me whether you feel sharp or dull, okay?
Okay, sounds good.
Sharp. Sharp. Dull. All right, so now for the actual treatment. You have some hair here, but I don't have any scissors. But if I did, I'd clip the hair. That way this can disperse more evenly. And since we don't have scissors, we can go ahead and add this dexamethasone medicine, which is a negatively charged treatment for lateral epicardialgia. And this is going to be the dispersive electrode, and it already has some saline solution on it. We're going to put it 4 to 6 inches away from the treatment electrode. And since this was a negatively charged medicine, we're going to add the black electrode to it. And this will be the positive electrode. Okay, and for dosage, we're just going to move this up to 80. We're just going to put the current at 2. And it will begin. I'm going to hit start. And it will configure the time for us. You'll have 40 minutes.